Hello, everyone. I think as hopefully some of you know, I'm David Suskind. I'm a pediatric gastroenterologist at Seattle Children's with a focus in inflammatory bowel disease and a focus in nutritional therapy in IBD. And I am going to share my screen. Let's see. Okay, and today I'll be talking about nutrition and immune balance, learning from inflammatory bowel disease. And as I think many of you who are on this call know, nutrition and diet have an integral component or aspect in IBD. And this is going to talk a little bit about both the science and the clinical studies that have been done to really emphasize why nutrition and diet is important in IBD. And this is my disclosure statement. So why should we focus on diet in IBD? And there are many, many reasons to focus on diet. One of the most important, if you look on to the left side of the screen, is that inflammatory bowel disease is really a disease of not only genetics, but environment. And you can see that by the increased incidence of IBD over the last 50 to 100 years. You can see that in industrialized countries, the increase has been going on for a little bit longer, but in non-industrialized or newly industrialized countries in Southeast Asia, there has been this steady progression within the incidence of inflammatory bowel disease. And that really points to environment being a very important aspect of disease instigation and continuation. And a very important part of that environment is the diet environment we live in and the changes that have been going on over the last 50 to 100 years. Another really important reason why we should be focusing in on diet in IBD is if you look to the right-hand side of the screen, you can see some of the drug studies that have been done. And this is something called the SONIC trial. And this is a trial that used medication therapy, immunomodulators, azathioprine, as well as biologics, infliximab. And they looked to see how efficacious, how well these medications worked. And you can see that they do work, but not 100%. And for individuals, not always 100% for any one individual. And so there can be 40 to 50% of individuals who don't respond. And this is true for the vast majority of medications out there, that they're not 100%. And that's another reason diet is such an important reason to focus in. And then if you look at the pictogram on the bottom, what you see is the cost of IBD. Not only cost from a healthcare perspective, meaning that it costs the health system a lot of money in terms of treating individuals with IBD, but on a personal cost, the cost of medications, some of these medications can cost $30,000 per year per patient. And the cost of having active disease on an individual, both from an economic standpoint, but also in terms of life and lifestyle. So these are all important reasons that we need to focus in IBD or diet in IBD, and why we at Seattle Children's really try to push the envelope forward in terms of understanding diet's implication. So to understand diet, and where and how it is involved in inflammatory bowel disease, it's really important to understand inflammatory bowel disease in and of itself and how diet affects each of these different important aspects of IBD. So in IBD, there are three main areas that are affected. One is the fecal microbiome, or the 100 trillion bacteria that live within each and every one of our bowels. Two is the mucosal integrity. So the lining of the GI tract, which keeps those 100 trillion bacteria away from the rest of our body. And the third important aspect is the immune system. The immune system is in many aspects of the body, but the GI tract actually has a very robust immune system of its own. And this lies right under the mucosa and is actually continually on alert, looking for potential pathogens. Now, we know that there are many triggers to IBD. So we know that in IBD, there's a genetic component. So about 260 plus genes have been identified to be associated with the development of IBD. But everybody's genetic predisposition is slightly different, meaning that one individual genes are different than another. But we know that there are, again, environmental triggers. And here you can see a picture on the left-hand side of antibiotics. So antibiotics we definitely use to treat IBD, but if one doesn't have IBD, there is an increased incidence or association with antibiotic use and the development of IBD. And that is because it affects the intestinal microbiome. But diet too affects the microbiome. And diet not only affects the microbiome to change it to a more dysbiotic microbiome with kind of a more westernized diet, but it also breaks down the mucosa. So it breaks down that lining of the GI tract, which keeps that 100 trillion bacteria away from the immune system. And then what happens is the immune system actually gets revved up and causes inflammation. And that's the cycle of IBD. And in the end, we see a picture like this, where the intestines itself becomes inflamed, irritated, ulcerated, and that's when you get the symptoms. You get abdominal pain, diarrhea, weight loss, poor growth, and it's all interconnected together. So let's take each of these areas kind of one by one and to see what happens in IBD and also to see how diet is integrated into these areas. So as I had mentioned, the microbiome, which is 100 trillion bacteria within the intestinal tract. Again, every time an individual poops, about a third of that poop is just bacteria. It's just how much there is within each of us. But there's a shift of the microbiome in inflammatory bowel disease. So bacteria which are helpful, which make vitamins and break down food for us, they decrease, and increased are bacteria that kind of instigate an inflammatory reaction. So you see an increase in bacteria such as Enterobacteriaceae and a decrease in bacteria such as fecal Bacterium perniciae, and many other changes occur as well. And you may be asking yourself, well, how does diet interplay with that? And I think the best way of thinking of that is about how diet interplays with the microbiome is to think of kind of multicellular organisms, right? So if we had a a tiger, a dolphin, a panda, a gorilla, and cows, and we were just feeding all of these animals hay, right? Well, there wouldn't be any tigers or dolphins or gorillas, and we would have a large number of cows left over, because that's what cows eat. The same concept occurs with the bacteria within our GI tract and the foods that we eat. So certain bacteria like to eat different foods. And so by eating certain foods, you can actually shift your bacterium within a 24-hour period. And the bacteria in somebody who eats one diet varies fairly significantly from an individual eating another diet. And we can see that in humans as well. So this is a study by Rothschild and colleagues where they looked at over 1,000 individuals. And this study was done in Israel. And they looked at individuals who had very different genetic backgrounds. So they looked at Ashkenazi Jews, Yemenites, individuals from Yemeni, individuals from other Middle Eastern countries, individuals from North Africa, and Sephardi Jews, which are also from African and Spanish Jews. And they looked at their genetics and they looked at their environment. And a big part of that was the foods that they ate. And what they were able to see by examining these very complex systems was that environment, and specifically dietary environment, dominated over genetics in shaping the human gut microbiome or the bacteria within the GI tract. But there's more to the story, as we talked about earlier. It's not only the bacteria in the GI tract, but it's also that lining of the mucosa, the lining that keeps the trillion bacteria away from the immune system. And you can see here, I'm going to see if I can get a pointer. There we go. So you can see here, the little red dots are bacteria. So these are microscopic bacteria. And then you can see here in the green is the lining of the GI tract. The black is this microscopic mucus layer. So it's about 9 microns thick, so it can't be seen with the naked eye, but you can see that this mucus layer keeps the vast majority of the bacteria away from the lining of the GI tract. And that's extremely important because it makes sure that the immune system is not overwhelmed, which lies here down below in the epithelium. And what we know is that there are many foods that break down this mucus layer. And as you can guess, a lot of these are processed foods that we can buy and eat on a daily basis. They include emulsifiers, high-fat, high-sugar diet, thickeners like carrageenan and caking agents, and microparticles. And what they do is they literally break down that mucus layer. So this is a study that looked at maltodextran. And what you can see is the bacteria are getting much closer to that mucus layer, again, allowing the immune system, which lies in this area, to be triggered. And there are other studies showing very similar results. This is a study by Martinez Medina that looked at a Western diet, which was high in fat, high in sugar, in CBAC10 mice. And these mice are predisposed to developing inflammatory bowel disease. And what he was able to show was that it increased E. coli, which is, again, one of those bacterium that can instigate the immune system in IBD. But it also did something else. It also changed the lining of the GI tract. So here you can see that it actually expressed something called claudin-2. And claudin-2 is a pore-forming protein. This leads to that proverbial leaky gut. And it decreased, as you can see in this picture, MUC2. And MUC2 is a major component of that mucus layer that keeps the bacteria away. So again, there are many products, but also just a high-fat, high-sugar diet can have this effect on the GI tract. And there can be also a direct effect on the immune system itself. So we know that there are pro-inflammatory foods such as wheat germ agglutinin and amylase trypsin inhibitors, and there are anti-inflammatory foods that are such as isothiocyanates and polyphenols. And as you would guess, these are the foods that are, whole foods, natural, and that usually have a fair bit of color within them. Now, all of that is fine, from a hypothetical standpoint, but are there dietary interventions that we use in IBD, and how do we use them, and how well do they work? And the answer obviously is yes. There are definitely a number of different dietary interventions that have been shown to be efficacious. The best studied is something called exclusive enteral nutrition. And exclusive enteral nutrition is when you take a formula and a formula alone as your sole nutrition for about 8 weeks' time. And this is actually a mainstay of nutritional therapy in Crohn's disease. It's not only been shown to be efficacious, but it's been shown to be so efficacious that it's actually recommended as a primary therapy by the North American Society of Pediatric Gastroenterology, my society, as well as the European Society of Pediatric Gastroenterology. Now, the difficulty is that with exclusive enteral nutrition, there is no other food or drinks allowed, and except for water. And individuals sometimes get what we call formula fatigue, or it's hard to drink the same formula each and every day for that 8-week period. So sometimes individuals will get nasogastric tubes. And if you look at the picture, you can see this is a few of us in our IBD center here at Seattle Children's on IBD Day, and we all placed our own nasogastric tubes to do exclusive enteral nutrition for the day. So it is something that's doable and something that is quite efficacious. Now, in terms of the studies, again, this has been probably the best studied nutritional intervention thus far. There have been what we call meta-analysis of multiple smaller studies, and you can see one here. And this study shows that EEN works equal to steroids, which is a common medication therapy that we use in Crohn's disease. But it does something different. If you look here, this is a study by Borelli and colleagues, and you can see that in active Crohn's disease, again, half of the patients in the study went on to steroids and half of them went on to EEN. And you can see that they actually work equally as well. This is the PCDAI, or a measure of disease activity for any one individual. And you can see that the steroid group, as well as the formula group, both went into clinical remission equally as well over a 10-week period. You can also see that the labs, the CRP and the sedimentation rate, the two labs that we often follow in Crohn's disease, actually normalize equally as well with both steroids and EEN. But why EEN is so much better than steroids is seen here. where you see mucosal healing. Steroids, while they do help some individuals have mucosal healing, didn't actually make a big dent in terms of mucosal healing for the vast majority of patients in this study, as opposed to EEN. So with EEN, you actually saw statistical improvement in mucosal healing for the vast majority of patients. And mucosal healing is extremely important in IBD care because it not only affects how patients do in the short term, but also in terms of long-term management. So this is one of the most important reasons that we really focus on EEN as a therapy in IBD. And what you can see in terms of the EEN, and this is a study by Pigneur, and actually duplicated the initial study that I just showed you by Borelli, is that the microbiome is shifted very differently with steroids versus EEN. So here you can see right before the treatment what the microbiome looked like. And this is just an axis kind of focusing on different individuals and what their microbiomes look like. EEN shifts the microbiome in one direction, while the steroids shifted the microbiome in a different direction. And this may be one of the reasons why we see much significantly better mucosal healing with EEN versus steroids. Now, many of you may be asking, well, is EEN effective in adults? And if you looked at some of the research, it would say maybe it's not as effective in adults as in pediatrics. But I would kind of argue that this is likely related to compliance and not actually whether it truly works better or not. So the studies that showing it not working as well allowed patients to just drink the EEN. And again, I had mentioned something about formula fatigue, where it's very difficult to drink the exact same thing for a prolonged period of time. In two studies, one by Okada and one by O'Moraine, they made the patients place a nasogastric tube to get the formula over the 8-week period. And in both of these studies, they worked, the efficacy was the same or similar to that which we see in pediatric patients. So there is now a new shift in the adult world where many adult practitioners will start utilizing EEN as a nutritional therapy as well. Now, there is other research that has been coming out, and although this is, a focus on the SCD, I think it's really important to know kind of everything that's out there. And this is a study that came from Israel by a group out there that looked at partial enteral nutrition or using formula, but formula not 100%, with something called the Crohn's disease exclusion diet, which is very similar in some ways to the SCD, but not quite the same thing. And what they did was they enrolled individuals with active Crohn's disease, and they put them either on this formula with 50% calories coming from the foods that the CDED diet and 50% of the calories coming from a formula called modulin, versus just modulin by itself. And they followed them for 6 weeks, and then they changed in the diet. The EEN group went on to 25% modulin and then eating whatever the individual wanted, versus the other group that continued on the CDED diet and 25% modulin. And they looked at them both at 12 weeks. And what you can see here is that the EEN and the modulin groups actually worked pretty similar in terms of getting patients into clinical remission, meaning that both groups, patients felt better overall. And what you can see here at the 12-week mark is that individuals who were on the CDED diet with 25% of their calories coming from formula, and then the rest on the CDED diet, versus those who went on to just a regular diet with 25% of the calories. If you ate a more restrictive diet like the CDED diet, you are much more likely to stay in clinical remission. While a regular diet, more individuals actually went into active disease again. But what was really interesting was what also happened to their inflammatory markers. So if you see here, the blue column is the calprotectins, or the stool inflammatory markers at baseline. And you can see both groups had elevated calprotectins. And then over the first 6 weeks, which is represented by the orange column, you can see that the calprotectin in both groups came down really significantly. And both groups, again, did really well. But when the next 6 weeks came, the CDED group, which again is an exclusion diet, their calprotectins continued to go down, as opposed to the EEN group, which went on to a regular diet. Their calprotectins went up to about 1,500, really emphasizing the impact of what we consider a regular diet on inflammation in and of itself. Now, what we're really here to talk about also is diet as a primary therapy, a whole foods diet as a primary therapy. And there have been many different studies in terms of diet in IBD. The two best studied diets are going to be the Mediterranean diet and the specific carbohydrate diet. And we'll go into these a little bit more in detail. Now, I probably don't need to tell this group what the specific carbohydrate diet is. I am sure that everybody here knows this extremely well. But the SCD, as you know, is a diet which restricts grains, sweeteners outside of honey, dairy outside of hard cheeses and yogurts, and the vast majority of food additives. So it takes away a lot of the more processed foods that we see in the Western diets today. And it really focuses on whole foods: fruits, vegetables, meats, and yogurt fermented over a 24-hour period. And we've done a lot of smaller studies, which kind of I'll go through right now, but we've actually also just recently completed a multi-center study called the Produce Study, which I'll also be going through shortly. So this is one of our initial studies that we published in 2018. And this looked at pediatric patients with active Crohn's disease and ulcerative colitis. And patients came into the study without changing any of their medication regime, if they were on any medication, and didn't add any medications during the study. And what you can see is clinically, patients who had both Crohn's disease and ulcerative colitis did well. So this is, again, an activity index called the Pediatric Crohn's Disease Activity Index. And this is an index called the Pediatric Ulcerative Colitis Index. And the dotted line is where we note remission to be. And so what you can see is that over a 12-week period, patients' symptoms improved fairly dramatically in this initial study. But what was also extremely important was that their inflammatory markers, both their sedimentation rate as well as their C-reactive protein, improved, and for many normalized as well. For this initial study, we also examined the microbiome, the bacteria within the GI tract. And this is an analysis of just one of the patients. But I just wanted to show you this to show you the dramatic impact that the foods that we eat have on the microbiome. So these are just some of the bacteria within this single individual. But what you can see here is that patients' E. coli and Rumenacacus ganavis, two bacteria which are implicated in IBD, were fairly high at baseline, so 12.3 and 15%. But what you can see over a 12-week period is that they dramatically drop down to about 0.2 and 1.9%. And we think that's why individuals had such improvement in terms of their symptoms and inflammatory burden. Now, this is another slide which shows the microbiome of all the different individuals. And just like a fingerprint, everybody's microbiome is pretty unique. And so everybody's microbiome shifted, but the shifts were different based on the foods that they were eating and what their underlying microbiomes were. But again, showing the dramatic effect of diet on the microbiome. So our next study is again in Crohn's disease, and this is a diet blinded study. In this study, we wanted to see if the diet had to be a strict SCD, or if we could liberalize it and get a similar effect. And so 10 patients enrolled in this study, and we had a chef prepare the food for each patient, and they went on to one of three diets. They either went on to a whole foods diet, a modified SCD, which added in oats and rice, or an SCD diet in and of itself. And we followed, once again, their clinical scores as well as inflammatory burden. And what we found was, this is the strict SCD, this is a modified, and this is the whole foods, that eating healthier just in general made people feel better. So by eating both a modified, a strict, and a whole foods diet, their symptoms decreased dramatically in each group. And now this is a small study, so not able to really show statistical significance per se, but again, showing us that what we eat really does matter. Now, we also looked at the inflammatory burden, and this is the CRP, and you can see that it improved in each group, but definitely the SCD and the modified SCD had a bigger impact than the whole foods group. So we subsequently moved forward with the produce study, and the produce study is what we call an N of 1 trial. So each patient that enrolled in this study was their own control, meaning we changed the intervention between the usual diet, the SCD, and a modified SCD, and compared to how an individual did with each of the diets themselves. And we also, is a little more of a prolonged study. This study itself lasted 32 weeks. And we used a mobile app to track how patients were doing through the study. And again, in this study, the modified SCD was defined with the addition of rice, oats, sweet potatoes, maple syrup, unsweetened cocoa powder, cacao powder, nibs, or butters. And we gave a minimum and a maximum serving size. So I'm going to show you how to read a probability figure. And I do this just because I think this is a little bit different type of study. And so it can get a little bit confusing, the figures themselves. And so the first thing to look at when we look at the data here is that some of these patients were full completers, some of them were early completers, and some of them withdrew because the diet was not working for them or because it was too difficult to maintain. Then the next thing to note is that each row is different. So the top row compares the SCD diet to a baseline diet. The middle row compares the modified SCD to baseline. And the bottom row compares the SCD to the modified SCD. And then the last, or not the last, but reading a probability figure is that the columns themselves represent each individual and the likelihood that one diet was working better than the other. And each one has Crohn's disease versus UC compared to all the patients in aggregate. And what we're looking for is a black line that goes over the 50% mark. And that means that it's most likely the first diet is most likely better than the second diet. So this is the PROMIS score for GI symptoms. And what you can see here is for full completers, meaning those that were able to really finish the entire study, that the SCD was much better than their baseline diet in terms of symptoms. In addition, the modified SCD seemed to work equally as well for symptoms. And when we compared the SCD to the modified SCD, we can see here that they seem to work equally as well in terms of symptoms. And this is another look, but looking at specific symptoms, including pain and diarrhea and blood in the stool. But once again, SCD and modified SCD work better than baseline. Modified SCD and SCD themselves seem to be comparable. But as we talked about before, it's not only in terms of symptoms, it's also in terms of the inflammation in IBD. And this is the fecal calprotectin results. And each result or each marker looks at a different time point within the study. And when we kind of aggregate them to make them look a little bit more clear, you can see that the initial line here is baseline. This is first SCD, first MSCD, second SCD, and second MSCD. And what you can see is that overall for full completers, individuals actually did quite well in terms of their inflammatory burden. So there was a significant shift downwards of the inflammation itself. And there wasn't actually a big difference between SCD versus MSCD, which tells us that, for some individuals, we may be able to liberalize the diet over time. And I'll answer questions on this because I'm sure this will bring up some really interesting questions by the audience in the discussion period of this talk. So In the end of the study, the vast majority of patients continued on with a modified SCD because it seemed to have worked well for them, as well as because it allowed a more liberalized diet. One individual continued with the SCD itself, and then one individual actually started enteral nutrition afterwards. So you may also be asking, well, what is the data for the SCD in adults? And there's been a recent multi-center study called the DINE-CD study. And this study, which looked at about 190 patients, compared the specific carbohydrate diet to the Mediterranean diet in Crohn's disease patients with mild to moderate symptoms, and looking for, was there a difference in symptomatic remission, as well as a difference in biomarkers of inflammation. And so this study, patients came in with mild to moderate symptoms. They didn't necessarily have to have active inflammation on their labs, but if they did, that was definitely taken into account. And they were randomized to either the specific carbohydrate diet or Mediterranean diet. And all the food was prepared for the patients. So it tried to keep it as blinded as possible. And then at 6 weeks, the patients were able to go on to either we were able to continue the specific carbohydrate diet or Mediterranean diet, but they had to do it on their own. So this is the 6-week outcome. And what you can see in terms of symptoms is that the Mediterranean diet and the specific carbohydrate diet seem to work equally as well in terms of improving symptoms. And so about 43 to 46% in terms of symptomatic remission, and clinical remission about 47 to 48%. So very similar. In addition, both seem to have a fecal calprotectin response in about 30 to 34%. The C-reactive protein, interestingly enough, did not improve dramatically and was about a response seen in about 3 to 5% of patients in the study. At 12 weeks, we see very similar numbers. So 40 to 42% with symptomatic remission, and in terms of clinical remission, 40 to 46%. But at the 12-week mark, those on the SCD seem to have more likely to have a fecal calprotectin response, as well as CRP response. So again, statistically, no difference between the two groups, but a trend towards better improvement with the SCD. So the question often comes, well, how do we use dietary management in IBD here at Seattle Children's? And there are two individuals or two groups that we really see that we are using more dietary intervention in. One is patient and family driven, and this is usually secondary to a hesitation to use medication therapy, secondary to potential side effects. The other is disease driven, and this is when a patient is not fully responding to our standard medical therapies. And in both situations, we use dietary therapy very similar to that of medication therapy. So we will instigate it and follow up with our patients quite closely. And that's the most important aspect of any intervention that we use, is that we're really wanting to make sure that we see the response that we need to show that it's efficacious. So I'm going to leave with a clinical case, and this is a young man who actually started some of the dietary journey with me earlier on in my career. And this is a 14-year-old young man who presented with a 3-month history of abdominal pain, loose stools, and weight loss. Patient was noted to be anemic and had elevated C-reactive protein, the marker of inflammation in IBD, and underwent endoscopy and colonoscopy. And you can see here that his terminal ileum is fairly inflamed. And family wanted to avoid medication therapy. And so we talked at length in terms of, what this would look like. And we decided to move forward with exclusive enteral nutrition and then to the specific carbohydrate diet. And he has been in clinical remission and laboratory remission for actually over 5 years on nutritional therapy. And he underwent endoscopy and colonoscopy, and he had complete mucosal healing with normal histology. And this really emphasizes the impact that dietary intervention can have in IBD. And it's why we need to help support each other in terms of making sure that patients, as well as providers, feel comfortable with this intervention. So dietary advice for the individual. Well, IBD is so personal, right? Every individual is different, and every individual comes from their own perspective. And so it's really important for us to meet our patients where they are and support them with the intervention that's going to be work best for them, as well as what they feel comfortable with. So it is a very individual situation. But what is most important, no matter what a individual, a patient is looking for as terms of treatment, is that diet really does matter. And whether you are on medication therapy and doing well, or if you are utilizing the SCD, the key is making sure that we emphasize the importance of diet and support all of our patients. And with that, thank you very much, and I'm happy to take any questions.
Thank you so much, Dr. Suskind. This is Jeffrey Berger. Thank you so much. It was outstanding presentation you delivered. Diet does matter. So it was interesting just going through all the diets, and I think anything away from the standard American diet is going to help your IBD, and I think giving out the variations that have been out there definitely supports that. And it's finite, to get down to why it's happening, why the specific carbohydrate diet, the modified, the Mediterranean, why are they doing so well to the gut microbiome? I think is that unanswered question, or the question we keep on asking ourselves.
Yeah. And, and one of the things I think is so interesting and so important to really emphasize is that it is very individual. And so, despite, or not despite, because of the research that is coming out, we still utilize SCD here at Children's as our main dietary intervention. But because we're also seeing that some individuals can bring in foods, we have a very standardized way of integration of other foods. If a patient or family wants to bring in foods, we don't say it has to, because SCD by itself can be is a very balanced diet, and you can definitely get all the nutrients, micro into a diet with that. But for those individuals who are doing extremely well, we'll sometimes start adding in foods in a very standardized way, but we do it very cautiously, because we aren't able to predict who will respond negatively and who will be okay with the addition. And so we will bring in one food, we'll check labs, make sure everything's looking great. And then we'll bring in one food and then recheck labs 4 to 6 weeks after, just to make sure there isn't any bump in the inflammatory response. And so we still kind of focus initially on the SCD, but then we'll bring in other foods down the road.
What is the difference between the SCD baseline, modified SCD, and MSCD?
Okay, so modified SCD and MSCD are the same things. The M is for modified. Modified SCD really means that you're bringing in non-SCD foods. In our clinical practice, we initially did that with the addition of oats and rice. And we, again, did it in a very stepwise fashion for each patient. So it's adding in one item at a time and seeing if somebody has a positive or a negative reaction to that, both clinically as well as through the labs. And so we'll do that. For the produce study, which is the study that looked at the most modified SCD that we've done so far, the modification was the addition of rice, oats, sweet potatoes, maple syrup, and cocoa. And when we add in foods, again, we make sure that it's not taken in excess. So usually about 3 times a week, a single serving size. So again, it's trying to find that right balance when we add in foods for modification.
What is the normal fecal, excuse me, what is the normal fecal calprotectin results to be expected for a pediatric or an adult with inflammatory bowel disease?
That's a great question. So normal fecal calprotectin is usually less than 50 for the general population. When utilizing a therapy, and that is whether it's medication therapy or dietary therapy, lower is always better. Different individuals, different programs will try for different markers. Usually I will go for less than 120, but there are some programs that do less than 250. So it really is, it's not an absolute, but lower is definitely better. Again, I use 120, but other programs also use 250 as their number.
Thank you so much. I know it's difficult to generalize, and I know that in the clinical study, 50 was done out of a study with the subjects that were used. Of course, they didn't look at what diet they were using at that time either. But I was wondering, has there ever been a study to correlate or show that a fecal calprotectin result of 50 means that your tissue pathology biopsy from your colonoscopy would show normal disease or mild or no disease activity?
So yes. So I mean, you mean, is there a correlation between less than 50 and mucosal healing?
Correct.
There is. Now there are caveats to that because each test has kind of nothing in this world is absolute, and that's why we always recommend making sure that the mucosa is completely healed by a colonoscopy, even if the calprotectin is normal. Small bowel disease, calprotectins are less accurate than colonic disease. And so sometimes you can miss things if they're occurring in the small bowel with just a calprotectin. It's much more accurate for the colon itself.
Is there any type of supplements that you recommend, like curcumin or L-glutamine for gut healing?
It's a great question too. So my perspective is that less is more, and so because the power of dietary intervention is so great, I usually just focus on that. I did a study early on with curcumin in colitis, and we it was well tolerated, and patients did seem to do okay with it. So that is something that if somebody wants to consider, we support. L-glutamate, I've actually had some anecdotal positive effects on for some of my patients who have not completely improved with diet alone. But overall, again, I try to minimize the amount of supplements people take, because I think that sometimes it can become overwhelming, and you don't always know what's in supplements themselves because it's a non-regulated industry. The two supplements that I'll do sometimes more often is vitamin D, because I live in Seattle and everybody's vitamin D deficient up here, including probably myself, as well as a multivite.
There's been statements, and you had answered this in a previous presentation you did regarding a colonoscopy and whether or not the preparation wipes out all the good bacteria from the progress that one makes while following the specific carbohydrate diet. Do you have any thoughts, or is there any background to the point that a colonoscopy preparation may actually not be helpful?
So the microbiome is this ecosystem, right? It's made up of, again, trillions of bacteria. And when you do a colonoscopy, yeah, you flush out a lot of the bacteria. There is no doubt. But again, you don't flush them all out. A huge number are still there, and they repopulate extremely quickly. So you don't wipe out your whole microbiome with the colonoscopy, and it'll repopulate. And we have not seen issues with flare or other problems after colonoscopy. So from my perspective, it's so important to know what's going on inside, because even with medications, right? Medications, people can feel fantastic, but you can still have a fair bit of inflammation going on. And that is important in terms of kind of long-term care, because that inflammation can lead to more likelihood of complications like stricturing and abscesses and things of that nature, as well as nutritional issues that we are concerned about. So again, it's always balancing, positives or negatives of any issue, and in this case, having a colonoscopy to assure that there is mucosal healing is extremely important.
With inflammatory bowel disease and autoimmune disease, there are times where people will get a secondary disease or extra intestinal disease, such as joint pain with arthritis, Hashimoto's, and other types of autoimmune diseases that come with it. including eyes and vision. And does diet help? And does changing the gut microbiome have these connections to the mind body, to the lung, to the heart?
Yeah, I mean, it's a great question. So a diet definitely has been shown in extremely good studies to have a big impact on cardiovascular disease. There's no doubt. You had mentioned heart. With other kind of autoimmune issues that are and are not associated with IBD, the studies have not been done as proactively as they have been in IBD. There is some data actually coming from, I want to say, the Netherlands, where they actually utilized EEN, or exclusive enteral nutrition, as well as the SCD for JIA, for juvenile idiopathic arthritis, which has shown positive results. Anecdotally, we've definitely seen some individuals who have had more issues with anxiety or OCD have some improvement. The difficulty is, is that kind of a one-off and just specific to that patient, or is that something that we can generalize to a larger group? And we're still learning that, so to be determined.
How well can you assess what's going on in the small intestine with a colonoscopy if the scope cannot go beyond the ileocecal valve?
It's a great question. So you can go beyond the ileocecal valve into the terminal ileum, so the last part of the small intestines. And that last part of the small intestines, the terminal ileum, is actually one of the most frequently affected sites for Crohn's disease. But you're correct. There is this middle portion of the small bowel, or the gastrointestinal tract, which we're not able to visualize with our scopes. And in those situations, we will oftentimes get imaging if there's concern for small bowel disease, and that can be, CT, MR, as well as capsule endoscopy. So there are other modalities if we have concern of active disease in the small intestines.
One last question for you, and thank you so much for your generosity of your time. You had shown in the descriptions of the studies with clinical remission. Have you seen histologic remission with nutritional therapy?
Yeah. So yes, we absolutely have. So no study as of yet, and one day, if I have time, that will be the next step. So as I had mentioned, we utilize dietary therapy just like we utilize any medication therapy. So we have close follow-up with our patients, and we get endoscopy, colonoscopy, when somebody's doing well, a year to 18 months after initiation of the therapy to look for that mucosal healing. And yes, we've seen mucosal healing primarily with the SCD. I'm just trying to think. And actually, I've had a few children who had been on the MSCD that we scoped, and we saw mucosal healing. So the answer is yes, but we've also seen patients who have not had mucosal healing, and we adjusted therapy to make sure that that individual did well. But yes, the take home is I've definitely seen mucosal healing with dietary intervention.
Wonderful. Thank you so very much, Dr. Suskind, for your time. And It was great. Excellent.
Yeah.
So
Well,
much.
I appreciate it, and I appreciate all that you do and all that everyone who's on this call is doing. So thank you for having me.
Thank you.